Hi, welcome to the Tozer Lee Eye Center YouTube page. I'm Dr. Kevin Tozer. Today we're going to talk a little bit about cataracts. So you've just been diagnosed with a cataract and told you need cataract surgery. The question is, what does that mean? How do we do it? So we're going to go over a little bit of that with you today. First, some anatomy. So this is a model of the eye. You have your cornea, that's the front window through which you look. Behind the cornea sits the iris, that's the colored part of the eye. And immediately behind the iris sits a lens. When you are born, this lens is crystal clear, and it's designed to help focus the light on the retina. That's the part of the eye that actually senses the light. Starting sometime in your 50s through your 60s, and as you age, this lens slowly gets cloudy. When it's cloudy, it's called a cataract. Now you can imagine, if that lens is cloudy, there's a limit to what we can do with glasses in front of the eye. No matter what, you're still looking through the cloudy lens. You can't put a clean window in front of a dirty window, you're still looking through the dirty window. So the fix for a cataract is not necessarily more and more glasses. The fix for the cataract is to get rid of the cataract. To do that, we make a very small incision right here on the side of the eye. We go in, we break that cloudy lens up into a bunch of little pieces, and we suck it out. And in its place, we put an artificial clear lens. To the best of our ability, that artificial lens will have your glasses prescription built into it, which is why that after cataract surgery, in addition to seeing better, you often have a reduced need, and in some cases, no need for glasses anymore. Now surgery's fast, 5 to 15 minutes, typically painless, usually up and about doing normal activities the next day. I typically ask 2 weeks of no heavy lifting, 2 weeks of no swimming. Most normal things you're back to in 24 hours. We don't do both eyes simultaneous. You do one eye first, other eye usually a few weeks later. Now the surgery is routine in the sense we do it all the time. Of course, that doesn't mean zero risk. There's no such thing as zero risk surgery of any sort. Fortunately, this is a low risk surgery. And the chances of a vision threatening complication, where vision is permanently worse after than it was before, is typically far less than 1%. That's the risk of things like infection, damage to structures in and around the eye, needing other major surgeries. All of those things are very, very uncommon, but theoretically possible. Now, there are a couple common things that do happen. One, in about 50% of patients, at some point following the cataract surgery, they'll get a little thin film or membrane that forms on the back surface of the lens, called a posterior capsule opacification. Makes the vision get kind of hazy again. When that happens, it's a very, very easy 10 to 15 second laser procedure to break that membrane up. So it's very common, but not a big deal at all to fix. Another very common thing that happens is any surgery, including cataract surgery, can make eyes a little drier. So it's possible after cataract surgery, you might find yourself needing a bit more lubricant for the eye than you needed before. And in fact, someone who has a lot of dryness before surgery may need to advance their dry eye treatment before it's safe to proceed with the cataract surgery itself. The most common complaint is just vision not as clear as we were hoping. We're shooting for perfect 20/20 uncorrected vision. Obviously, we can't sit here and promise every single patient perfect 20/20, but we do our best to get as close to that goal as we can. Now, the question of when to do the surgery. There's really two requirements that have to be met in order to justify cataract surgery. The first is you need to have a cataract that's having a measurable impact on your vision. The second is that impact has to be bothersome enough to the patient to justify the surgery itself. It's that second component that's different for everybody. Some people are bothered by very mild cataracts because they may have a visual demand greater than somebody else. For instance, a pilot. A pilot may see 20/20 here in the office, but if they're bothered by glare or halos while landing planes, they're going to need cataract surgery at a far earlier level than someone that maybe has a different level of visual demand. Now, once you've decided you need surgery and you want to go forward with it, the next discussion comes down to types of lenses, because there are many different choices for the lenses. We're going to go over a couple of those right now. So there's the standard insurance covered lens. That's the lens that your insurance company will pay for, and it's typically a very good lens. That lens will focus your eyes at either distance or near, but not both. Additionally, that standard insurance covered lens does not fix any astigmatism. Astigmatism has to do with the shape of the eye, and in fact, a lot of people have astigmatism and have had it their whole life. Many people, when they get their glasses or their contact lens prescription, a significant percentage of that prescription is to fix the astigmatism. So, if someone has astigmatism in their eye, and we put a lens in the eye with cataract surgery that does not fix the astigmatism, then they're certainly still going to need glasses afterwards. Let's say we fix the astigmatism, which we certainly can do with surgery, and we focus the eyes for either distance or near, but not both. Let's say we put 2 distance lenses in, one in each eye. If we did that, what would happen is you would have very good distance vision, meaning everything past your arm would more or less be in focus with little to hopefully no need for glasses. But if we do 2 distance lenses, you're certainly still going to need reading glasses. That's arm's length and in. So things like reading your computer, reading your phone, your watch, those sorts of things would still need reading glasses if you do both for distance. Similarly, we can fix the eyes for near. So if we put 2 reading lenses, one in each eye, you'll likely have excellent reading vision. But then you would need glasses for everything past your arm. If someone is looking to get both distance and near, there's typically 2 ways to achieve that. One way is we take the dominant eye, whatever eye that is, we would check for it, and we'd focus the eyes the best we can for distance, fix the astigmatism if necessary. And then the other, not dominant eye, we leave it a little bit nearsighted. So you have one eye for distance, one eye for near. We call that monovision. Monovision actually works really well for most patients. The eyes kind of blend the 2 images together, and functionally what you're left with is good distance and near vision without constantly having to take your glasses on and off. The risk with monovision is not everybody's brain adjusts to it. There's certainly a percentage of people whose brain just says, nope, that's weird, wacky, they feel imbalanced, unsteady, whatever it is. And if someone does monovision and then doesn't like it, we'd have to reverse it after the fact with another procedure. If I have a patient who's been wearing contact lenses since their 40s and done monovision for 30 years with it, great, I know they're going to like it. For someone who's never done monovision contact lenses though, there's certainly that risk your brain doesn't adjust. The final option is something called a multifocal lens. A multifocal lens is a lens where each eye does distance and each eye does near. So the lens is focusing the light across a range of depths. Clearly, that's more versatile than just a distance or just a near lens, but the multifocal lenses also have some drawbacks. One big drawback comes in the form of persistent glare or halos at night. So while it does give very good vision during situations with good lighting, it doesn't give the best vision in low lighting scenarios. So I certainly wouldn't put a multifocal lens in someone who has a very high demand distance nighttime vision requirement. Again, I don't want that pilot seeing halos on the runway, so that person does not get a multifocal lens. Or a long haul truck driver working a night shift. Those people do not get multifocal lenses because we don't want them to be bothered by any of the glare or halos. For someone that says, hey, I don't drive at night much anyways, glare and halo is not a major concern, I'm just looking for good vision the rest of the time, the multifocal lens may be a very reasonable option. So one final thing I will mention as a lens choice is we do have lenses now that are adjustable. What that is a lens we put in the eye where it doesn't have to be absolutely perfect. We just have to get it somewhere in the ballpark of right. We let the eye heal for a few weeks, and then we can non-invasively, here in the office, adjust the power of the lens however we'd like. We call that the light adjustable lens. And it's really, really good option for patients that are trying to fine-tune their vision to a very precise level. Now, you may say that sounds amazing. Why would everybody not choose that lens? Well, it does have a couple drawbacks. One of the drawbacks of the light adjustable lens is that until we do the adjustments and lock-in treatments here in the office, that lens is adjusted by UV light, which means you got to wear these special UV protecting sunglasses whenever you go outdoors. Otherwise, the UV light from the sun is going to hit that lens and change it in some totally random configuration. That may be 6, 7, 8, 9 weeks after the surgery till it's all said and done, all the adjustments are finished, before you can stop wearing those outdoor sunglasses. The other downside of the adjustable lens is it's more visits. Normally with cataract surgery, there's a 1-day visit, maybe a 2-week visit, and that's kind of it. With the adjustable lens, you still have those visits, but then starting at week 3, you have at least 3 more, sometimes 5 more visits to do the adjustments. So it's definitely a bigger commitment of time. And then the final downside is any of these lens choices that are above what insurance would cover cost extra. So whether that's fixing the astigmatism or whether that's a multifocal lens, they cost extra. The light adjustable lens is not a multifocal lens. It's just distance or just near. There is currently no adjustable multifocal lenses. There's a lot that goes into deciding when to do cataract surgery, how to do the cataract surgery, and what lenses to use. Hopefully this was helpful, and if you have further questions, feel free to ask your doctor, or if you're my patient, myself, and we'll happy to go over it all again in more detail. Thank you.